Very good morning, respected Sonkar sir, Saxena sir, Kapoor sir, Malhotra sir, other senior faculty, and my dear colleagues. I am Dr. Manish Pahadia, Professor Medicine. I welcome all of you. Today we are here to discuss a very rare and very interesting case, a young lady, 35-year-old lady with paraparesis. The story of this lady is very interesting and I hope you all will be benefited with this presentation. For this, I invite Dr. Nipun Goel, second year medicine resident. Please come over the stage and start the presentation. Thank you.
A very warm good morning to respective dignitaries, teachers, seniors, and dear colleagues. A 35-year-old Hindu female, married, homemaker, uneducated, resident of Sikar, presented to us with the chief complaints of weakness of both lower limbs from 2 days and fever with dry cough from 2 days. History of presenting illness. Patient was asymptomatic 2 days back when she developed weakness in both of her lower limbs, which was sudden in onset, rapidly progressive. Initially, she had difficulty in wearing and slippage of slippers. Over the next 12 hours, she had difficulty in standing up from squatting position and had to walk with the support of her attendants. Weakness was associated with mild muscular pain in both of her lower limbs. There were no aggravating or relieving factors of the weakness. Weakness of upper limb was conspicuously absent. Fever was undocumented, of 2 days duration, low grade, continuous in nature, and relieved on taking oral paracetamol. Cough was of 2 days duration with no diurnal variation. It was dry, present throughout the day, and there were no aggravating or relieving factors. She also complains of grittiness and irritation of eyes from 15 days and dryness of mouth from 15 days. Grittiness and irritation of eyes was painless, present throughout the day, increased with rubbing, relieved by washing with water, not associated with any redness, discharge, blurring of vision, or photosensitivity. There was no history of any trauma or wearing of contact lenses. She also developed dryness of mouth. She had to drink water to swallow food and used to take sips of water to keep her mouth moist. There were no oral ulcers. She had a negative history of headache, seizures, loss of consciousness, blurring of vision, tingling or numbness, diarrhea or shortness of breath, bony or radicular pain, urinary or fecal retention, palpitation, trauma. There was no history of chills or rigors, rashes, joint or muscular pain, digital discoloration, night sweats, vomiting, burning micturition. She had no history of sore throat, hemoptysis, wheeze, chest pain, hoarseness of voice, and drug intake. She had a past history of similar weakness, around 6 episodes in the last 7 years, requiring multiple hospital visits. Her first hospital visit was in February 2017. Weakness was associated with low-grade fever and cough of short duration. She was usually admitted in daycare, got symptomatic treatment, and was discharged home on OPD basis. There was no history of any medical comorbidities and no history of any surgery or blood transfusion. Family history is not significant. She had she had two children, both of them are healthy. She had a drug history of COVID vaccination, 2 doses plus booster, no records available. She had a history of taking antipyretics from over the counter. There is no known drug allergy and there is no history of any other drug intake. She is vegetarian by diet, taking 2 to 3 meals per day, having normal sleep cycle with normal bladder and bowel habit, non-smoker, non-alcoholic with no drug addiction. So, to summarize the case, a 35-year-old female homemaker presented with weakness of the lower limbs of 2 days duration, sudden in onset, rapidly progressive without involving the upper limbs, with fever with dry cough, grittiness and irritation of eyes, and dryness of mouth, with past history of similar illness for which she attended hospital OPD 6 times in the last 7 years. So what could be the differential diagnosis? Anyone?
I think here.
Yes.
Thoda sa neurological syndrome should be described in a little more detail.
Sir,
Like, was the weakness from below upwards, above downwards, more distal, more proximal? Was there any symptoms related to sensory involvement? Those
yes,
things
sir.
are important.
So, there were no sensory symptoms. Sensory was normal. There was no bladder bowel involvement, and the weakness started from distal legs, and it was moving upwards. So, to find out the cause for acute onset paraparesis, we have divided on the basis of localization into central cause, spinal cord cause, radiculopathy, neuromuscular junction disorder, muscle disorder, metabolic or psychogenic. In central causes, it could be superior sagittal sinus thrombosis, cortical sinus thrombosis. Then there can be injury to the paracentral lobule. In spinal cord, we can have acute viral myelitis, Watt's paraplegia, compressive myelopathy, tubercular pachymeningitis, transverse myelitis, and anterior spinal artery thrombosis. In radiculopathy, it can be GBS or acute exacerbation of CIDP. In neuromuscular junction disorders, it could be myasthenia gravis or Lambert-Eaton myasthenic syndrome. In muscular disorders, it can be polymyositis. In metabolic, it could be hypokalemia or hyperkalemia or thyrotoxicosis. And in psychogenic, it can be malingering. So first of all, vitals were recorded. Her pulse was 110 per minute, regular, normal volume, normal character, no radial or radiofemoral delay with or peripheral pulses present. BP was 122 by 78 mmHg in the right upper arm. Temperature noted was 99.8 degree Fahrenheit. SpO2 was 98% on room air and respiratory rate was 18 per minute. Her general physical examination was almost normal. She was lying comfortably on bed, oriented to time, place and person, but her eyes were dry. In general physical examination, pallor was present. Respiratory and cardiovascular examination was normal. In GIT examination, her lips and oral mucosa was dry. Liver was palpable with a span of 16 centimeters. Spleen was also palpable with a palpable 1 centimeters below the costal margin. She was oriented to time, place and person, obeying instructions. Her MMAC score was normal, 30 by 30, and cranial nerve examination was almost normal. Since she has a complaint of breathiness and irritation, so cranial nerve second, third, fourth and sixth was examined. It was almost normal. Muscle bulk was normal and equal on both the sides. There was hypotonia in all group of muscles in the lower limb. Power was also 2 by 5 in all group of muscles in the lower limb. Reflexes were absent in knee and ankle, in right side and left side both. Sensory examination was normal. Lower limb and could not be assessed and gait could not be assessed. Rest cerebral examination was normal. So I would like to invite Dr. Sarthak Shah for further discussion of the case.
Good morning, everybody. Good morning, respected professors and my dear colleagues. So, summarizing the case till now, on the basis of the history and the examination, we have a 35-year-old female who presented to us with flaccid paraparesis. It was rapid in onset, lower motor neuron type, without any bowel or bladder or any sensory involvement, and of 2 days duration, with a short history of fever and dry cough, dry eyes, dry mouth, with past history of similar 6 episodes of weakness of lower limbs in the last 7 years. On examination, we could find there was pallor, hepatosplenomegaly, there was lower limb hypotonia with reduced power and absent deep tendon reflexes in lower limbs. So basically, on the basis of the neurological examination, we can make out whether is it a UMN lesion or an LMN lesion. Our patient has absent reflexes, hypotonia, flaccid paraparesis, there are plantaris flexor. Hence, we can make out that it is an LMN type of lesion. In UMN type of lesions, we will have hyperreflexia, there will be spasticity, plantar will be extensor. So, till now we can make out it is a rapid onset LMN type of weakness. Sir, in shock stage, we can have LMN type of lesions. So, like in spinal shock, we can have in spinal shock, usually we have at the site of the lesion LMN and below the level of lesion UMN. But in spinal shock, we will have LMN features even below the level of lesion. But in spinal shock, sir, patient with even having spinal shock, patient will have bowel or bladder involvement, and he can still have sensory symptoms. And plantar will be mute or flexor, but it wouldn't be extensor in spinal shock state. So hence, we can say that it is not a spinal shock. So after summarizing, I would like to ask the audience on the basis of examination, now what do you think are the possibilities?
So now, since we can see that it's an element region, we can rule out central causes of paraparesis. And since it was recurrent, also it goes more towards metabolic causes. There's no bowel bladder involvement, so we can rule out most of the spinal causes.
Here, in this patient, the red flags are multi-system involvement, right? Patient has fever, patient has splenomegaly, patient has eye-related, mouth-related symptoms. Patient is a young female, and very, very importantly, there are multiple episodes like this. So, what will you think of when you try to correlate all these things?
I will think more towards metabolic and autoimmune causes.
So, okay, good.
Right.
Firstly, even if it's lower motor neuron, you have to think it's a myopathy, it's a neuropathy, it's a neuromuscular junction. Fix that thing and then come to metabolic or autoimmune disorders. Don't jump to autoimmune or metabolic. As Dr. Balveen says, localization is most important in neurology. Etiology comes always second. So firstly think, what do you think? It's myopathy, neuropathy, neuromuscular junction. You have to think first and then the etiology.
Rightly said. So again, as we discussed right now, possibility of central causes seems very less likely, because in central causes mostly we will have a UMN type of weakness. There will be associated headache, seizure, altered sensorium, or any urinary incontinence. Again, in spinal cord, talking about anterior spinal artery thrombosis, POTS, paraplegia, transverse myelitis, mostly they will be having element type of weakness below the level of lesion. There will be any sensory involvement or a band-like sensation, and there will be a bladder or bowel involvement. Hence, possibility of a spinal cord lesion is also less likely. So again, coming down at radiculopathy of peripheral nerves, now these lesions can present as element type weakness. In that we have one of the differential diagnosis can be GBS. GBS points favoring GBS are it is a rapidly progressive bilaterally symmetrical ascending paralysis. Patient has element type of weakness which goes in favor of GBS. The only points against that there are multiple recurrent episodes history. Patient has had early recovery and there is no history of any preceding diarrhea or any UIT or any infection. Similarly, chronic inflammatory demyelinating polyneuropathy can also be considered, but points against them are that CIDP has a gradual and a progressive paraparesis, and the weakness progresses over at least 2 months. So again, after coming down from the peripheral nerves, we can consider the muscle disorders. In muscle disorders, we have considered there is a possibility of polymyositis. She is a young female with weakness, and the points favoring polymyositis are episodic weakness, myalgias. There is no sensory or any bowel bladder involvement. But points against till now are there is no cutaneous manifestation, no tenderness, no muscle atrophy, no fasciculations. Early recovery seems unlikely for polymyositis and pyrrhexia. So talking about neuromuscular junction disorders like myasthenia gravis and Lambert-Eaton myasthenic syndrome, points favoring are acute onset paraparesis, and points against myasthenia gravis or Lambert-Eaton are that there is no ptosis. Commonly myasthenia presents with ptosis or ophthalmoplegia. There are no such signs, bulbar or respiratory involvement, and usually there is in myasthenia gravis there is no improvement after rest, and in Lambert-Eaton myasthenic syndrome the weakness might improve with the activity. Coming after that, there is a possibility of thyroid myopathy. Again, points favoring thyroid myopathy are recurrent episodes and paraparesis. But till now, there are no systemic signs suggestive for any thyroid disorder. And lastly, we can come to metabolic causes, periodic paralysis. Now, periodic paralysis can be due to thyrotoxicosis, hypokalemic periodic paralysis, and hyperkalemic periodic paralysis. All three can present with recurrent paraparesis and acute onset. So the patient presented. So first possibility would be of any radiculopathy or peripheral nerve. I would consider GBS as one of the first. Sir, either a pure motor variant, or other than that, sir, metabolic cause can be a possibility because patient has had a recurrent episodes and acute onset paraparesis. So, you're right, sir. Yes, sir. Right. Yes, sir. So we. Right. Right, sir. So we just wanted to show the anatomical localizations. That why we mentioned it in that order, from top to bottom.
It's always good to go from first.
Most so,
then
right.
the setting and then second.
Yeah, you should put 3, 4
Right.
priority wise, your diagnosis, priority wise.
So the investigations done in the emergency, the ABG was suggestive for normal anion gap metabolic acidosis. The pH was on the lower end, bicarbonates were decreased, and patient's potassium was 2.1. Then an ECG was taken out. Now, can somebody tell me what are the changes seen in the ECG? Right. Correct. So after seeing the ECG, as rightly pointed out, there is flattening of T wave, inverted T waves. So these are the changes of hypokalemia which we commonly see. So T wave, flattening of T wave, inverted T waves. Along with that, there is prominent U wave, and there is also QT prolongation. So a normal QT is of 360 to 450 milliseconds. But in our patient, it was prolonged. It was around 520 milliseconds, and the corrected QT interval was also 580 milliseconds. So, in view of critical hypokalemia, one cycle of intravenous potassium supplementation was given through an infusion pump, and supportive management was started. Now, after a few hours, we noticed that in a span of next few hours, her weakness improved. Patient was stabilized to the ward. The patient was shifted to the ward after stabilization. Routine investigations and symptomatic management was started. A neurology opinion was taken, and nerve conduction study, MRI lumbar spine, and MRI brain was planned. After giving potassium, before the supplementation, the reflexes were absent. After supplementation, the reflexes were present. Her power also significantly improved in the lower limbs. From 2/5 in all group of muscles, it became 4/5. Investigations on day 1 showed us mild anemia, thrombocytopenia, ESR was raised. Serum potassium after supplementation was 3.7. And in the and we could also notice that the globulins level were raised with an AG ratio reversal suggestive for hypergamma globulinemia. Rest renal functions and thyroid profile was normal. So in the day 1 of evening, patient again developed weakness. Even after, so we send repeat electrolytes, and we noticed that patient again has hypokalemia. So again potassium supplementation was given, and oral supplementation of potassium chloride was started. Day 2, the MRI and nerve conduction velocity study came. It was normal. Patient's weakness again improved after.
Sorry to interrupt.
This.
Young lady who is on normal diet,
Right,
developing such severe hypokalemia.
Is it not more important to find out why she has developed that rather than doing MRI and other investigations?
So these investigations were done simultaneously on day 1 only, and I was coming to that only, that even after
No, but I am asking, is MRI indicated?
So that was because firstly when patient presented to us with paraparesis, for
But
that
we have
we
found
planned
because-
MRI. Right. So both the things were done
No,
in the same
My
day.
question is,
Right, sir.
young lady, you found the cause of paraparesis. Potassium is so low,
Right.
and it responded to treatment. So was MRI indicated?
So after getting this cause as hypokalemia as cause of paraparesis, then MRI is not indicated, sir. But to rule out,
According to me, MRI is indicated in this case.
right. So to rule out,
Simultaneously, we have to go, sir. We just when the neurological localization is necessary, whether it's central or peripheral.
See, I think more than this, Dr. Sarthak, what is not clear to me is you have given one cycle, 40 milliequivalents of potassium, and you have got your potassium from 2.1 to 3.7. Either 2.1 is wrong or 3.7 is wrong. to give 1 milliequivalent increase in serum potassium, you have to give at least 100 millimoles, including supplementing for losses. So if you had given, and you can't give 160 or 180 millimoles in 4 hours, and then the potassium will not fluctuate like this. So I guess that 3.7 is unreliable. The potassium, there was transient improvement as you were infusing, but you didn't really correct the potassium, and again the weakness has recurred. So, I mean, if you're doing potassium correction, this would be a good opportunity to tell the house how to correct serum potassium in an acute crisis like this, and one cycle is not the way to do it.
Right, sir. So this might be due to because the potassium shown was in the ABG. So because of that, and after that, this is a serum electrolyte. And secondly, sir, approach to how to manage hypokalemia. So, talking about that, hypokalemia can be normal values are between 3.5 to 5 milliequivalents per liter. So mild hypokalemia is 3.5 to 3. Sir, no significant changes were seen. So, talking about potassium correction in mild hypokalemia, we can simply give oral potassium chloride, and the dose to give that is around 10 to 20 milliequivalents 3 to 4 times a day, and maximum we can give is 60 to 100 milliequivalents in a day. If patient has critical hypokalemia severe, which is less than 2.5, then we should consider giving patient intravenous potassium chloride. What we supplement over here, we take two ampules, each of 20 milliequivalents potassium chloride. Along with that, mixed in 30 ml of sodium chloride over 12.5 ml per hour, which basically means 10 millimoles per hour over 4 hours. So, if there is severe hypokalemia, even then we should give it at around 20 milliequivalents per hour in 3 to 4 times. And after supplementing 1 to 2 cycles, we should first repeat the electrolytes, which should check whether the potassium has been corrected. And if it has been corrected, we can stop. Otherwise, we can supplement another. But the maximum we can give is 100 milliequivalents per day.
I think that is, you need to be a bit more aggressive than that. You have to give 100 millimoles to get 1 milliequivalent improvement. Because 1 milliequivalent per liter improvement in serum potassium still keeps you at 3.1. You are starting at 2.1. Your deficit is easily 200 millimoles plus. And this is severe hypokalemia with a critical involvement of the peripheral muscle. All you now have is that now if phrenic nerve and diaphragm gets involved, the patient has to go on a ventilator for simple things like hypokalemia. So I think the aggressive correction with a central line placement and one cycle is 40 millimoles, which are given over 3 to 4 hours. You can do that in this aggressive situation if you use a central line or an EJV. I would have thought that more aggressive potassium correction, number one. Number two, I think Vinay's point, Dr. Kapoor's point that what is the cause of this hypokalemia? The patient is not vomiting, patient doesn't have diuretic use or losing fluids. Why is there this hypokalemia? That also needs to be addressed.
Yes, sir. So we are.
As far as the correction of hypokalemia is concerned, the aggressive route is fine. But in our setting, even if it increases by say 5 ml or 4 ml, there is always a risk of some cardiac damage.
So we are monitoring them in the,
It's in the, yes, you are right, sir. It's in the ICU basis with a constant monitoring at that time. We are talking of the management which started in the emergency. And we all know that potassium management, even if we exceed by 1 ml, can be dangerous. So we have to strike a balance. Yes, yes, but even in routine settings, even slight increase in the drop rate can be deleterious. So we have to look at the setting where the patient is being treated. And yes, you are right about the aggressive part. But potassium aggressive management, we have all seen in our experience, at times can be dangerous for the patients. Except it with proper monitoring. Yes. Yes, yes, that's right.
So you can't give aggressive correction and do it in the ward and forget the patient for about 24 hours. Monitoring is easy.
I think that what Dr. Saxena is saying is very right, because we do embryo reduction using the potassium chloride solution, injecting into the heart of the embryo. It is very dangerous, so cautious to be on the lower side and take a more time, gradual. This is what I feel.
Isn't there a formula for calculating the potassium for correction?
Yes, sir. There is.
You haven't mentioned that so far.
Right, sir. So we can basically potassium deficit is. So potassium correction, sir, I've mentioned it over here. Yes, sir. So I mentioned it in the lower end. So by mixing 2 ampules each of 10 ml, each ampule consisting of 20 milliequivalents in each vial, making it 40 milliequivalents, with 1 ampule of 2 ml 1 gram MgSO4 mixed with 28 ml of normal saline So that makes it 50 ml infused at 12 ml per hour, making it 12 millimoles per hour potassium supplementation over 4 hours.
The original potassium level. Every patient same thing.
No, sir, since our patient has, like I said, if it is mild hypokalemia, we can simply give oral potassium chloride. In severe or critical hypokalemia, we'll have to use intravenous potassium.
The formula is for calculating the deficit, but correction would always be at this level because otherwise, irrespective of the amount that is needed.
One is I think you're justified to gradually uptake the potassium because ABC has very, fallacious electrolyte reading. So I think that part is done nicely. And then everybody is asking the cause of recurrent hypokalemia. And you are not highlighting the acidosis part in the ABC.
Yes, sir. So we are covering all those things in the next few slides. So that's why till now. So sir, on day 2, जी sir. So then for further evaluation, we also sent CPK to check for polymyositis. Serum cortisol was sent, which was also normal to rule out mineralocorticoid excessive state. So summarizing, after the investigations, we have a 35-year-old female who has paraparesis, rapid onset lower motor neuron type, fever, dry cough, dry eyes, dry mouth, with past history of similar episodes in the last 7 years. On examination, we have an element type of weakness, pallor, hepatosplenomegaly, and ABG suggestive for a normal anion gap metabolic acidosis, recurrent hypokalemia, bicytopenia, hypergamma-globulins, and USG suggestive for borderline hepatosplenomegaly. So after summarizing, what could be the closest possible diagnosis now? So basically, after like we discussed, central causes cannot be the possibility in either spinal cord. GBS has been ruled out on the basis of normal NCV. CIDP similarly, no symptoms suggestive for myasthenia gravis. Similarly, normal thyroid profile and no hyperkalemia is there, we ruled it out. So the only differential left with us is hypokalemic periodic paralysis, which basically due to persistently low levels of serum potassium, weakness improving after potassium supplementation, and patient has a history of multiple episodes of paraparesis. So now we came to the point that our patient is having recurrent hypokalemia. So what are the causes for recurrent hypokalemia? So we started evaluating the causes for recurrent hypokalemia. Either it could be decreased intake, starvation, but our patient did not have that. There could be GI losses, like patient could have diarrhea, GI loss, excessive sweating, perspiration, or burns, but patient has no such history. It could be due to redistribution on the cells. If somebody is taking insulin, beta-2 agonist, or due to thyrotoxicosis can cause redistribution into the cells, but there was no such history. So coming to the renal losses, increased distal flow or increased sodium delivery by the use of any diuretic or osmotic diuresis, but our patient doesn't have any such history. Causes for increased excretion of potassium. It could be either due to mineralocorticoid excessive state, but we already ruled that out. And other than that, it could be either a proximal or distal renal tubular acidosis, diabetic ketoacidosis, or any channelopathy. So to further evaluate for the renal cause of hypokalemia, we took a nephrology opinion, and in view of dry eyes, we took an ophthalmology opinion. So I would like to call Dr. Rajat from the Department of Nephrology.
Good morning, everyone. Thank you, Sarthak. Respected faculty and my colleagues. So I'll be discussing the part of evaluation of hypokalemia. So as it has been established that this case is of recurrent hypokalemia, and since it has a history of past 6 years, so most probably patient has a chronic hypokalemia. So how do we go about evaluating it? So this is a simple flowchart. How do we evaluate a case of hypokalemia? The first thing whether we should rule out it's a pseudo or redistribution. As Sarthak has already explained, redistribution occurs in case of drug history, like a patient is on insulin, beta adrenergics, that causes the shift of potassium from ECF to ICF. Then the second part, if there is no evidence of redistribution, we go for whether the potassium is lost from GI or renal. Now, history-wise, we can rule out GI in most of the cases, as it is simple history of recurrent vomiting, recurrent diarrhea, malabsorption syndromes. We can point out it's a GI cause. So if we see and dehydration also. Otherwise, if history is not suggestive of a GI cause, then we think of a renal cause. That's the most like distal tubule in the nephron is the most sensitive part for potassium management. So ideally the first thing that we should measure is a urinary potassium. So normally urinary potassium will be less than 20 in case of a normal patient with a non-renal cause of potassium loss. So we should measure the, so in the evaluation chart it is always said to measure a 24-hour urinary potassium, but in clinical practice it is more difficult to measure that. So we do a spot urinary potassium test that is equally effective as a 24-hour. So if it's more than 20 millimole, so we should consider a renal cause. Now, if you come into a flow chart, if we go, yes, it has more than 20 millimole, then ideally we should next evaluate the BP of the patient. So, in case of a hypertensive patient, like if the BP comes high, then we evaluate plasma, aldosterone, and cortisol. These are two primary hormones that regulate the BP. So in case of a, like the first we go for a common cause. What we have seen in a normal condition in the medicine cases we can see. There is low aldosterone or normal or there is a high cortisol. Then we have to think of Cushing syndrome that can be caused by secondary steroid abuse or anything. Or the second cause is high aldosterone and there is a normal cortisol level, that is a primary hyperaldosteronism or secondary. These are two more common cases that we see in the medicine. The third one, that is low aldosterone with a normal cortisol level, it is a Liddle syndrome. Basically, Liddle syndrome is a activation of ENaC channels in proximal tubule that acts like the receptor is getting aldosterone, otherwise the body is not making it, is automatically getting activated and it is causing hypokalemia. If the BP of the patient is low, then we have to think of a Bartter or Gitelman syndrome. Now, how do we see in the evaluation of hypokalemia? Along this hypertension, we have to also always look for ABG status of the patient, whether it is acidosis or alkalosis. As Liddle syndrome, Bartter syndrome, and Gitelman syndrome, all these syndromes have a metabolic alkalosis in the ABG, not metabolic acidosis. And our patient, as we already established, it's a metabolic acidosis with a normal anion gap. Now, if we come to the second part, we have evaluated the BP, and in this case, it's a low BP. The second part, we have to take a proper drug history again. Is there any drugs such as diuretics, aminoglycide, amphotericin? All these drugs affect the distal tubule of the renal, which causes a defect in potassium absorption. Second, the most common causes will be the renal tubular acidosis. And third is the hypomagnesemia. So it's a simple flowchart. The common causes that we should focus on evaluation is the RTA and aldosterone and cortisol levels. This will give us a maximum diagnosis in these cases. So the second important part, as we know, we have to know the ABG status of the patient. So in our case, we already established some metabolic acidosis, not alkalosis. So ruling out half the diagnosis from the chart. Now, in case of metabolic acidosis, the next part we should know is anion gap. The simple anion gap formula is sodium minus chloride minus bicarbonate, and a normal value will be 12 plus minus 2. In this case, the anion gap was 9. So that comes into a normal anion gap metabolic acidosis, and since the albumin of the patient was normal, there is no need for correction in this case. Now, what is the anion gap? Just the basic of anion gap. So anion gap, as we calculated, it's a sodium minus chloride minus bicarb. And the unmeasurable anion gap, that's mostly the negatively charged amino acids that we can't measure by lab. That is the anion gap. So there should be a equivalent of positive and negative ions. So this unmeasured part is the anion gap. Now there are two types of metabolic acidosis. There can be high anion gap or non-anion gap. So the high anion gap, this unmeasurable part of anion gap amino acid is increased, and the common causes for high anion gap metabolic acidosis is diabetic ketoacidosis, starvation ketoacidosis, alcohol intake, and these are the common cause that we can see. And in case of normal anion gap, in this the chloride part is increased and the bicarb and the non-measurable anion gaps are decreased. And the most common cause of normal anion gap metabolic acidosis is RTA. The other causes of non-anion gap can be surgeries like pancreatic fistulas, small intestine fistulas, urinary diversions. These can also cause non-anion gap metabolic acidosis. But in the case of medicine setting, most common will be a RTA. Now, the next step, we have to further, we want to further confirm whether it is a GI loss or a renal loss. We can use a urinary anion gap. That's the next step we can do to further confirm our diagnosis.
So in case of just a brief about urinary anion gap, formula is basically urinary sodium plus potassium minus the chloride. It reflects the urinary bicarb and urinary ammonium balance. So in case of there is extrarenal bicarb loss like diarrhea or vomiting, so to balance it out, urinary ammonium ion production is increased. So in case of a GI loss, urinary ammonium ion increased, urinary bicarb will be normal, so the urinary anion gap will become negative. However, in case of renal losses, in case of proximal RTA, there is increased bicarbonate wasting. So there is increased bicarb, urinary bicarb. However, urinary ammonium ion remains the same. So there is a positive urinary anion gap. And in case of distal RTA, it mainly affects the secretion of the H plus ion. So there is again urinary bicarb will remain same. However, urinary hydrogen ion will decrease. So again there is a positive urinary anion gap. So this further confirms whether it is a GI loss or renal loss. So in this case, the urinary potassium was high, that is 36. Urinary sodium was 50 and urinary chloride was 62. And the urinary anion gap was 24, that is a positive. So we further confirm that this is a case of potassium loss from renal source and it's probably a RTA. Now we have to see whether it is a proximal RTA or distal RTA. So commonly there are three types of RTA that we see: type 1, type 2 and type 4. Now type 4 RTA is a hyperkalemic RTA. So we've already ruled out this is not a hyperkalemic RTA. Now we have to see whether it is a type 1 or type 2. Type 1 is distal RTA, type 2 is a proximal RTA. So these are very similar in sick, like serum potassium will be low in both, kidney functions will be near normal. Now the main differentiating point can be a urinary pH. As it is previously mentioned in this case, the patient has a urinary pH of 5.5. Usually in case of high acidemia, urinary pH might decrease as the renal will try to further excrete the potassium hydrogen ion. So in case of type 1 RTA, there is failure of acidification. That is the primary pathology in this. So even if you increase the acidic load in the body, urinary pH won't go down below 5.3. So there is a separate test for that, urinary acidification test, usually not done. There are two types of tests in that. You can give ammonium chloride tablets or you can give furosemide or plus fluorocortisone test. So that is usually not done. In this test, after this test, if the urinary pH doesn't go down below 5.3, then it's a type 1 RTA. In type 2 RTA, urinary pH will decrease in acidosis. Now serum bicarbonate level is a variable in both. Usually there is more acidosis in type 1 RTA. Urinary citrate, that is an important clue we can see. So usually urine citrate test is not done, but in case of urine citrate is low, it leads to nephrocalcinosis or nephrolithiasis. Since citrate is a potent urinary citrate, basically prevents stone formation. So in this case, type 1 RTA, the urine citrate is low, leading to more further stone formation in the renal calyx, and in this case the patient had a left nephrolithiasis. So again this is an indicator that is a this patient is a type 1 RTA. And the Fanconi syndrome, basically Fanconi syndrome dictates it's a proximal RTA defect, and proximal RTA defects have multiple findings in urinary findings that can be glycosuria, phosphaturia and other protein loss. Since this patient had urine routine as a normal, there was no glycosuria, no proteinuria, again we rule out that's a type 2 RTA. So this means all of this, it is strongly indicates that it's a type 1 distal RTA, normal anion gap, metabolic acidosis in this patient. I would like to invite Dr. Ayush for further.
The patient was referred to us from Department of Medicine for complaint of grittiness and irritation in both eyes since 15 days. The symptoms had no associated pain. They were present throughout the day. They increased with rubbing. They were relieved by washing with water. They were not associated with any redness, blurring of vision or photosensitivity. There was no history of any trauma, foreign body or contact lens wear. We performed a suite of ophthalmological examinations on the patient. The conjunctiva showed mucous discharge in both the eyes. The pupils were round, regular and reactive. The visual acuity of the patient was 6/9 in both eyes. The intraocular pressure was 16 millimeters of Hg in both eyes, which is normal. The extraocular movements were normal in all directions of gaze. The slit lamp examination demonstrated superficial punctate keratitis in both eyes. The anterior chamber was of normal depth and there were no cells of flare present. So here we have a zoomed in image of the cornea taken via the slit lamp. showing diffuse intraepithelial grayish-white opacities, which were indicative of superficial punctate keratitis. The fundus findings were normal in the patient. So, based on the patient's symptoms and findings, they were indicative of a dry eye ocular surface disorder. So we decided to proceed with diagnostic tests for dry eyes. Dry eyes is basically classified into two types, which is aqueous deficient and evaporative. Aqueous deficient, we use the Schirmer's test. For evaporative, we use the tear film breakup time, TBUT test. Before proceeding to the diagnostic tests, I would like to give a brief overview about the tear film and its layers. The tear film is composed of three main layers. This is the inner side, the corneal side, and this is the outer side, which is the air side. The inner side begins with the mucus layer, which sticks to the cornea, and it converts the cornea from a hydrophobic to a hydrophilic surface, which enables the effective attachment of the next layer, which is the aqueous layer. The aqueous layer is the thick, bulky part of the tear film, and its main function is to provide hydration and oxygen permeability to the cornea. Next comes the lipid layer, which is the outermost layer, and its function is to prevent the evaporation of the aqueous layer. Sorry. Yeah. So these three layers are produced by three different parts of the eye. The mucus layer is produced by the goblet cells of the conjunctiva. The aqueous layer is produced by lacrimal and accessory lacrimal glands, and the lipid layer is produced by meibomian glands, which are present in the eyelids. So we perform the Schirmer's test first, which is for the aqueous layer. The Schirmer's test is, the Schirmer's test, we take the tip of the Schirmer strip and we place it into the inferior fornix of the conjunctiva at the lateral 1/3 and medial 2/3 junction. We insert the patient to close their eyes and we wait for a period of 5 minutes. Due to capillary action, the tear film proceeds into the Schirmer strip, and there is a dye present here, and the dye diffuses along with the tear film. So at the end, we have a marking on the tear strip, which gives us a grading in millimeters, which we use to assess the production of tear. The Schirmer test result in the patient was, in the right eye was 6 millimeters after 5 minutes, and the left eye showed no wetting at all. Next, we perform the tear film breakup time test, which is for the lipid layer, the outermost layer. Here we use a fluorescein strip or 2% fluorescein eye drops. We instill it into the eye, and we observe the eye through a cobalt blue or a red-free filter, as in this case. And what we observe is the time from the blink to the appearance of the dark blackish areas, which are areas of dryness, where the tear film has dried up and has started breaking. So normally it is 10 seconds, more than 10 seconds is what we consider normal. And in the patient it was 8 seconds in both eyes. Dry eye grading is based both on the TBUT time as well as the Schirmer test grading. So TBUT more than 10 seconds is normal, Schirmer more than 10 millimeters in 5 minutes is considered normal. In the patient we had 8 seconds of TBUT, and Schirmer's test showed 6 millimeter in the right eye and 0 millimeters in the left eye. So the findings were indicative of an aqueous deficient type of dry eye, with right eye having a moderate grade and left eye having severe grade. The classification of dry eye, as discussed previously, is of two types: the aqueous deficient type and the evaporative type, based on the layers. The aqueous deficient has Sjogren syndrome as the primary cause, as well as non-Sjogren causes such as lacrimal deficiency, lacrimal gland or duct-related issues, reflex block of the fifth nerve, certain systemic drugs that decrease tear production. Then we have evaporative causes, which are divided further into intrinsic and extrinsic based on the causes. The intrinsic are related to the body itself, which are things like meibomian oil deficiency disorders, eyelid aperture, low blink rate, computer vision syndrome, which is pretty common nowadays due to increasing amount of screen time on mobile phones and computer screens is part of this. The low blink rate kind of evaporative dry eye. While extrinsic factors, we have factors outside the body that affect us, which are vitamin A deficiency, certain topical drugs and the preservatives used in them, contact lens wear, which is again a very common cause nowadays. It is also evaporative type of dry eye, and ocular surface diseases such as allergies. To summarize, the patient had symptoms indicative of dry eye in both eyes since the last 15 days. The slit lamp examination demonstrated mucus discharge with superficial punctate keratitis in both the eyes. Based on Schirmer's and TBUT, we diagnosed the patient to have an aqueous deficient form of dry eye with the moderate in the right and severe in the left. And the patient was prescribed tear substitutes in the form of eye drops and eye ointment for the same. Next, I'd like to invite Dr. Sarthak to continue this presentation. Thank you. So, after taking all the findings, in view of a normal and metabolic acidosis, recurrent hypokalemia, distal renal tubular acidosis, and a positive Schirmer's test, we thought there was a high possibility of an underlying autoimmune disease causing all these things. So we sent out ANA by immunofluorescent assay. It was positive. To confirm that, we sent the ANA profile, and the profile was positive strongly for anti-Ro anti-La antibody 3+. So hence this confirms everything, and this makes everything in order. Sjogren's syndrome with Sicca features causing distal renal tubular acidosis, and the female is presenting to us with recurrent hypokalemic periodic paralysis. So the patient was discharged on tablet hydroxychloroquine 200 mg BD, alkali supplementation tablet soda bicarb was given, and a potassium-rich diet was advised, and syrup potassium chloride was also given. And patient was called after 15 days for regular follow-up. This was the electrolyte trend in our hospital, and this is she's our patient after a 1-year follow-up. Now she's currently on tablet HCQ 200 mg OD, potassium-rich diet with regular monitoring of serum electrolytes. Now I would like to call Dr. Tapas to throw some light on Sjogren's syndrome.
Good morning, everyone. Basically, Sjogren's is an autoimmune disease characterized by chronic autoimmunity, lymphocytic and plasma cell infiltration with destruction of salivary glands, and two types of Sjogren's are found: primary and secondary. Primary is associated with Sicca features. Sicca literally means dry. Xerostomia and xerophthalmia, and associated with HLA, DRD, and secondary is mostly associated with other autoimmune diseases such as connective tissue disorders, rheumatoid arthritis, SLE. Incidence is 4 per 1 lakh, with 70% having primary. Prevalence is 0.2 to 2.7% of the population. Female to male preponderance is 10:1, with peak incidence in 4th and 5th decade. Amongst the clinical features, the constitutional symptoms include fever, fatigue, dry cough, white sweat, pain, and the glandular involvement includes dry eye, dry mouth, dry skin, dry vagina, and extraglandular includes arthralgia, kidney, glomerulonephritis, renal tubular acidosis, small vessel vasculitis, peripheral neuropathies, and lung involvement. Amongst the hematological involvement, anemia, leukopenia, thrombocytopenia, or either of the combination might be found. There is a picture showing dryness of eye and tongue with hypoglobulation and fissuring. Amongst the approach to diagnosis of Sjogren's, the important feature of the classification includes the Sicca, the dryness symptoms, which apart from other features involve most of the cases with hypokalemic periodic paralysis plus renal involvement. ACR EULAR classification criteria has been used since 2017 on a scale of 9. More than 4 is considered as primary Sjogren's. Amongst the lab tests, the confirmatories are autoimmune antibodies by IFA and anti-Ro and anti-La. More specifically, amongst other, elevated ESR, blood counts derangements including anemia, leukopenia, thrombocytopenia, abnormal LFTs, rheumatoid factor, and hypergammaglobulinemia. This case was reported in Scopus Index Journal, Journal of Indian Academy of Clinical Medicine by Sanna sir. And amongst the review of literature, most of the cases have been, all the Sjogren's have been mostly presenting in either renal involvement or hypokalemic period paralysis with mortality risk. If the gamma globulin levels and rheumatoid factors are associated with it, it might lead to complications such as lymphoma in later part of the life, with risk ranging as per the populations from 5% to 40% risk बढ़ जाता है same age group में compare करने पे. And management is basically started with hydroxychloroquine immunomodulators. If not controlled by that, we go for cyclophosphamide. And in conditions when it flare up, we used to give steroids. Many case reports have been reported, including paralysis, acidosis, rare complications in pregnancy, but not taking the home messages. Not all paraparesis are neurological, but may be attributed to the metabolic causes too. And any patient of recurrent paraparesis with hypokalemia must be worked up for Sjogren's syndrome also. Stepwise approach towards investigations, more guided by clinical thought, is more appropriate and cost effective. The diagnostic workup of Sjogren's is easily available and cost effective. At the end, we could relieve the patient of an illness she had been suffering for years with simple potassium supplementation. And as it is said that whenever in doubt, we should take help. Thanks to our Emeritus Chairperson, sir, Chairman, sir, Chancellor, sir, Vice Chancellor, sir, Pro Vice Chancellor, sir, Principal and Controller, Medical Superintendent, sir, MGUMST Management, CCR Review Committee, Department of Rheumatology, Nephrology, Ophthalmology, Nursing Staff, and most important, the patient and his family.